get all the panelists to come up to the stage, please? I know we're running a little bit late, but I've been told we can extend our questions for a few minutes. So please, just as a reminder, if you come up to ask a question, maybe introduce yourself, where you're from, and if there's a particular person that you would like to identify. And I don't know if we have any virtual questions, but we can bring those first. But why don't we do first the ones in the room? Tom Hurley.
There it goes.
It's on now.
All right, there we go. Tom Hurley, Indiana University. So Dustin, so the allele distribution, E2, E4, differences between your cognitive normals and the other group. Just curious, what's the general population distribution, and which of those two distributions is closer to that?
Admittedly, I am not a geneticist, and Liana would have been able to field that question much more than I. But when we are looking at Heidi Weinberg distributions, our cognitively normal group tends to fit much more of the expected E2, E3, E4 distributions throughout.
Thanks, Tom. Another question over here on the left.
Mostly for Dr. Dage. My name's Amy Cotty. I'm a mass spectrometrist, and I'm for hire. But actually, a question about, you have this really cool assay that says you have this potential risk. What does it look like to talk to an IRB and enroll patients in a trial when we can't be sure what that risk is down the line?
Yeah, so I mean, it is really complicated, but we have done it. So there's a lot of biomarker studies, like especially in Sweden, the BioFinder study, but there's also the ADNI study where we're looking at this longitudinally. And you know, in terms of the treatment studies, you know, those are run by industry, so I can't really comment a lot on that. But you know, I think it's such an unmet need. I think what you have to look at is the inclusion, exclusion criteria that you have, and really staying focused on people who this is the primary risk. And you know, that does do what I think Dustin pointed out. It reduces your population to be not representative of the broader, you know, world. And that's what we see even with Leqembi and with donanemab trials, right? Is they're not representative of the broader world. And that is always a concern, because then when they get approved and you start treatments, you have risks that you didn't get to see.
Thank you.
Dr. Zaghi.
Thank you. I really enjoyed the presentations. I have two brief questions. The first one is for Dustin. I noticed you've got about 9% of the non-AD individuals with ApoE4 homozygous genotype. I assume that the ages were very similar, the age distribution. So has anyone sequenced these individuals, done studies to really find what is the suppressor of the phenotype in these individuals?
That is an excellent question. And Kelly Noodleman, the geneticist on the team, is starting to undertake all of those finer grade analyses. The data that I presented, and admittedly that the entirety of the special issue that we presented on was really just the introduction of leads and the EOAD cohort to the field. And so we are looking into all of those, and including much more thorough investigation on a genetics end. I only listed ApoE4 or the various genotypes of ApoE. However, much more investigation has already been done that I did not have time to include regarding specific rare genetic mutations, et cetera.
Thank you. And then my next question is for Jeff. I noticed with the phospho-217 of tau that there were a handful of non-AD individuals that had really slightly. Have these been followed more carefully? I mean, are you following them to see if they're going to convert at a point in time? Are their ages similar, or could they be a little younger? I'm just curious. Yeah,
they're in that scatter plot from the Lancet Neurology paper. So absolutely. So a bunch of those patients had autopsy, and at UCSF they follow them to autopsy. And there's a few case studies that we're really excited about, where they do have really high tau, but they're confirmed amyloid negative, and they have or high phospho-tau. And so as we look at that, we're learning all kinds of really interesting things. Typically, what we see, especially in like the FTLD cases, you'll have just a really abundant tau pathology. And so when you think about grading Alzheimer's disease as a tauopathy, FTLD as a tauopathy, and even like CVD, you kind of have these, grades. And Alzheimer's disease seems to be one of the most, extensive. And I think that's probably part of it. And so some of these cases really are just showing a really, I don't want to say aggressive, an abundance of pathology.
Great. Dr. Dilworth Anderson, I think, had a question.
Thank you. I have a question for the panel. Any one of you could answer, or all of you. I think Jeff mentioned the data do not reflect real life situations, and which translates into real life people. With the next iteration of science, and we're sort of especially with AI on the horizon, what are our perspectives on being more inclusive? Because the people, as we all know in this audience, who are left out are the people at greatest risk for almost everything you've talked about today. So the new science moving forward in terms of where we're going from here, especially in the translational area, which leads to better care ultimately. What are your thoughts on that?
Yeah, I might just make a quick comment, because I mean, that's one of the things I'm most passionate about in terms of the blood test is really leveraging that to engage and to meet different people that are previously inaccessible to research. So if you have to come to a PET center, that's a big barrier for you to be involved. Well, okay, if you go to your phlebotomist, that's local to you at a CVS or whatever. Well, okay, you can donate blood. Well, we're working now on can we do it in a blood spot card, so we can mail it to your home and you prick your finger like a diabetes test and just put 2 dots on it and send it in. Now that barrier is even more reduced. And these kinds of things are the kinds of things what we have to recognize is there are these barriers that prevent people from being part of research. And we have to eliminate those barriers. And I look at this blood test as just one way that I can do it myself, and I push that as hard as I can, because I think it is about accessibility. There's certainly a million other things, but accessibility for me, and what we can do and still maintain the high quality of care, the high quality of diagnostic accuracy, but make it accessible to everybody.
I can comment also from, and Dustin can probably elaborate, but from a neuropsychological point of view, something that COVID made us much more able to do is teleassessment. And we've been able to reach about, I would say in our studies, about 40% higher levels of individuals from minoritized groups and bilingual individuals who we couldn't reach before, especially being here in the Midwest, where we were inherently limited in Southern Indiana. And we're also partnering with the Center for Rural Engagement at IU and a few other places as well to try and kind of reach more rural communities who do now, almost all of them have pretty decent internet enough to do a neuropsych assessment. So that's helping as well.
Yeah, Dustin, I don't know if you wanted to comment at all.
Certainly, what you are raising is absolutely vital. We are at a point in particular, so today happens to be the rollout of the Indiana University's lecanemab clinic. So the transition from research trials to clinical treatment for Alzheimer's disease, FDA approved. And there's been a lot written about the issues of representation in the samples that have been that have been used as the basis for FDA treatment. And it is appropriate that there's been a lot written about that. And I fear we're going to continue to see some of that as we are rolling this out. The fact that unfortunately lecanemab is an infusion-based, it's not a pill-based, which means there's a limitation, there's a bottleneck of how many folks we can impact based on the number of infusion seats we have available, which means that folks would need to have had a full evaluation, a full workup, making sure they have amyloid scans to ensure that the disease, that we're tracking the right disease, et cetera. This costs money. This costs, at the current time, this costs, it needs insurance to cover that, because rates of a amyloid PET scan are around $5,000. Most people can't afford that. And particular, that is going to expand health inequities. So some of the research that Jeff is talking about and some of the ideas of making this a finger prick, the hope really is that we can bring this to much more represented populations. Additionally, in speaking with the LEADS population specifically, we've been incredibly fortunate to receive the funding from the Alzheimer's Association for the diversity supplement. That has allowed us to pivot and allow much greater focus of reaching out into the community, having the ability to focus with community advisory boards, to make sure that we're talking to folks, make sure we're developing trust in the community, to eventually be able to have data that when we talk about early onset Alzheimer's disease, everyone can look at that data and think that it represents them and not just highly educated, wealthy white people.
Yeah. Sure.
Because I feel this is very critical to the health and welfare of our nation. And in these kinds of settings, which I've been in more times than I can count, that we need to pause, I think, and start talking about where do we go to get good science, new policies and different approaches. Because we have the evidence is not accessible to everyone. You know, as Jeff noted, I'm one of the architects of the diversity supplements for the Alzheimer's Association. I was on the scientific board when that happened and made sure that became institutionalized in this country. Now, one of the things that I would strongly recommend for all of us in here to think about is that we know where we've been, we know where we need to go, and that we need to work collectively to let people know in this country that we care enough about them to have them in our research. And I'll be speaking shortly, and we'll be speaking to this, but we have enough brain power to do this. And I'd like to advocate, while I have the mic, we as researchers have not included social workers on our teams who know how to get into these communities. We have not incorporated public health experts on our teams. We have great minds on these teams, but we oftentimes don't have people who have the people experience to help us think about how do we reach people versus, in addition to what I'm studying that will get to the people. So as we move toward this, I really want to say this to the young scientists: expand your teams, be inclusive, increase your teams with social scientists, allied health scientists, as well as the biomedical scientists. So I'm going to stop there.
Okay, thank you so much. And on that note, we're going to close this session, and we want you back in 12 minutes for more continued conversation of that. Thank you, that topic. Thank you very much.